Rahul, let us know if I can start. We are ready to go. Okay, it's 8:05 and we are ready to go now. So I welcome you all on behalf of Society for the Study of Pain Pune for this webinar on regenerative therapy part 1. That means we have part 2 for next month. So I welcome all our speakers and viewers and SSPP members for this webinar. And I would like to invite our President, Dr. Varshali Kenia, to start the session.
Thank you, Varsha. Yeah, good evening to everyone. So after a gap of maybe 2 months after the ISSP Con, very successful ISSP Con 2024, we as a Society for Study of Pain Pune are enthusiastically starting the webinar series for this year. And to start with, we have very interesting topic, which we have divided into 2 parts. So initially we'll have a peripheral blood cells based regenerative therapy. And in the second part, we will have a non-peripheral blood regenerative therapy. This is very interesting topic, and as we do more and more pain practice, more things come up in the armamentarium and everyone is so inquisitive, what is it? So let's hear from the experts. So I welcome the speaker for today, Dr. Jeyaraman, and I am very obliged for him to have you here. And I also welcome Dr. Sanjog and Dr. Manas, and I would like to ask Manas to start the session. Ask Sanjog to start the session. He is moderator for today. So yes, Sanjog, you can carry on forward.
Yes, thank you. Thank you. So, good evening, everyone. As we know that regenerative medicine has emerged as a very promising frontier, and not only in the pain medicine, but also in various other sectors, various other specialties. Everyone, orthopedicians, neurosurgeons, everybody is trying to find out what is there in regenerative medicine. And we started some years back with some simple airlocked 10 ml PRP tubes. But with time, more and more research and work being done, various preparations are coming in the market. Some are having activators, some are without activators. We are shifting slowly from cellular to cellular preparations now. And now with all this rapid growth in knowledge and the opportunities that are coming into this field, the clinical physician, the practitioner is actually also getting confused what to use, when to use, and how to go about exploring this field. So that's why we thought of starting this webinar with this interesting topic of exploring what are the new trends in the treatment modalities related to the regenerative medicine. So I would like to first invite our first speaker for today, Dr. Manas Manohar sir. He is a consultant pain physician and anesthesiologist and director of Specklin Superspecialty Clinic and attached to also various other hospitals in Pune. He has various publications in national journals, invited as faculty in various conferences. He's also working on some AI-related project for ultrasound-guided pain procedures. He has special interest in interventional pain medicine and regenerative medicine in chronic pain conditions. So I request Dr. Manas sir to please share his slides and start his brief talk on and his talk is on the basics classification of the different regenerative methods. Welcome, Manas sir. You're not audible, sir. You have to remove the mute. Yeah.
Yeah, so I was saying that since it's a vast topic which we need to cover, I will just give a short presentation on the basics of regenerative medicine, what regenerative medicine is, and overall classification of whatever orthobiologics that we are using. So it will be a very short presentation so that we give enough time for Dr. Madhan to explore the topic of blood-based regenerative medicine in detail. So let's understand what is pain medicine. Regenerative medicine. So regeneration and healing. So regenerative medicine focuses on harnessing the body's natural ability to replace, repair, and regenerate damaged tissues or organs. It involves innovative therapies. Like Dr. Sanjog said, we initially started with simple techniques like PRP. Now we are evolving with techniques to autologous conditioned serum, stem cells, adipose, bone marrow, so on and so forth. So it involves a cutting edge therapies like stem cell treatments and which can be game changers for chronic conditions which seldom have any definite cure. And also with regenerative medicine, we can personalize the treatment depending on what the patients need. And even in advanced conditions, with the help of gene therapy coming up, we can make our treatment more directed towards the specific needs of the patient. So let's have a brief view about history of regenerative medicine. So if we go back, the roots of regenerative medicine can be tracked back to the ancient civilizations where natural remedies and healing practices were used to treat various conditions. As and how we have progressed, we have done a lot of scientific progress and we are making significant breakthroughs in blood-based regenerative treatments, bone marrows, adipose cells, even umbilical cord, and so on and so forth. And gene therapy is one which is coming up very fast. So with all this scientific progress, we have had a lot of clinical applications from experimental treatments to mainstream medical practices. So this is a very exciting field, and I think all of us should take cognizance of it, learn about it, and then we can apply it in our clinical practice. So let's compare regenerative medicine with our traditional medicine. As all of us know, traditional medicine basically focuses on symptom management and disease treatment with the use of mainly pharmacology and surgical procedures, which are mostly kind of replacements and which do not really deal with the basic pathology of the disease. So they do not have a real long-term solution for chronic conditions. Whereas regenerative medicine targets the root cause of these diseases by repairing, healing, regenerating, and it offers potential cures. And especially this is true in cases of chronic conditions which do not have any proper or definitive cure. So an ideal way to practice this would be an integration of traditional medicine with regenerative medicine, so that we can complement both these therapies, and this can enhance patient outcomes, and we can provide holistic care, especially in conditions which are very complex to treat. So again, what are the benefits of regenerative medicine? Basically, as we can guess from the name, regenerative medicine is used mostly in degenerative conditions. So it's an imbalance between regenerative factors and degenerative factors. And that is why degenerative factors take over and we have the so-called condition that we are dealing with. So with the help of regenerative medicine, we try to shift the balance towards the regenerative factors, and that results in reduced pain. The process of regeneration itself leads to reduction in pain. Regeneration in actual is the end stage, but the process of healing or the process of regeneration is what gives pain relief to the patients. Obviously, it reduces inflammation, and being minimally invasive, these procedures have minimal risks. They reduce recovery time and often are very good alternative solutions to traditional treatments. So let's have a look in brief about what are the types of regenerative therapies that are available. So they can be classified into cell-based therapies, gene therapy, and tissue engineering. So cell-based therapies, to summarize, like it's a stem cell therapy, platelet-rich plasma, which all of us are using day in and day out, and bone marrow concentrate aspirate. So they utilize the regenerative potential of the stem cells to heal or repair damaged tissues and organs. And also certain stem cells or even blood-based products have immunomodulatory and regenerative properties. So that can also help in treating chronic inflammatory diseases like, say, rheumatoid arthritis or ankylosing spondylitis and so on. Gene therapy is a very advanced form of therapy. It is especially being used in non-curable conditions like spinal muscular dystrophy and certain malignancies. So it's a very complex topic which involves gene editing, viral vectors to deliver therapeutic genes into target cells, which can offer potential treatment for genetic disorders and various gene transfer techniques. One more topic for research, I would say, is tissue engineering, which involves using of scaffold-based approaches, bioprinting technology, and decellularization techniques. This is just to complete the list. Now, coming to the practical aspects of what we are using day in and day out, we may call it as orthobiologics. So, if we want to classify orthobiologics, we can classify them as first, second, third, and fourth generation. So, first generation being a very simple one, which all of us have started with, is hyaluronic acid. Second generation, PRP, comes into a second generation. Third generation is bone marrow aspirate concentrate, and fourth generation is adipose-derived stem cell, mesenchymal stem cells. They can also be classified according to the source that they are derived from. So if we are looking at blood-derived products, we have PRP, we have autologous conditioned serum. Bone marrow-derived products are bone marrow aspirate concentrate, bone marrow-derived pluripotent mesenchymal stem cells. Many of us are doing adipose stem cells now, so fat-derived orthobiologics are there, which can be stromal vascular fraction fat or microfragmented adipose tissue, which is also called as MFAT. Other sources are umbilical cord derived, amnion or placenta derived, like Wharton's jelly, amnion membrane, cryopreserved amnio fluid, and exosomes to last but not the least. Exosomes are really coming up, and it could be game changers if we can have access to them. So these are the orthobiologics that we are commonly using in our practice, and clinical applications in select patients can lead to success stories. We all have seen that regenerative medicine has shown promising results in restoring cartilage and joint function, and offers hope to patients who are dealing with arthritis. Research is underway to explore regenerative therapies for conditions like spinal cord injuries, neurodegenerative diseases like Sanjog said, everybody is into regenerative medicine. All specialties have showing interest in it, especially for non-curable diseases. And we also have we also know various famous athletes who have benefited from treatments of regenerative injections. Nonetheless, there are a lot of challenges and limitations in using regenerative medicine. First is there is always a risk of immunological rejection. If this especially holds true if we are using allogenic products and not autologous products. Ethical concerns are always there because there are certain cases where doctors have overclaimed to the patient that they will cure it, and that has landed them into trouble. And obviously, before starting any regenerative medicine procedure, you should be well aware of the regulatory hurdles that are there with the regenerative medicine. So we should be all very aware of what are the regulations regarding the use of any particular modality that you're using, and you should abide by them thoroughly. So the importance of regenerative medicine, it is that it is making medical breakthroughs in various fields, and that is why we being pain physicians, we should know about it and really dig deeper into it as we progress into our practice. It has led to enhanced healing of degenerative conditions and conditions which are complex to treat, and shows promise to offer long-term solutions to these patients. So, I end my presentation here so that I can hand over to Dr. Madhan for a more interesting topic.
Thank you, sir, for this comprehensive presentation on basics of regenerative therapy, just to kickstart a series that we are planning on regenerative medicine. Now, we'll take the questions, I think, at the end. And I would next like to invite our next speaker, Dr. Madan Jeyaraman. Dr. Madan Jeyaraman is Assistant Professor of Orthopedics, ACS Medical College and Hospital, Chennai. You can see that he has done many fellowships related to the regenerative medicine, related to arthroscopy and its various applications in various fields like sports medicine. He also received the SICOT Research Award in Belgium, and he is also the associate editor of many journals, IGO, JCOT, GCOT, and JOREP, and IGOR. He has published around 280 plus articles in national and international journals. So he has keen interest in research, and we had a short discussion about this, about the work that he's doing. And he's doing great work in related to the scaffolds and biomaterials which are required for the support of chondrogenesis or cartilage regeneration. We surely talk about that also, sir. And I request you to please share your slide and start your presentation, sir.
Thanks for the warm welcome. Let me start my presentation. Is my slide visible?
Yes, the slide is visible.
Yeah. Please. Let me start the topic proper. Peripheral blood-based regenerative therapy. So now what we all need is evidence-based medicine. So in this evidence-based medicine, we need clinical expertise, then best possible research, and further patient values. Whatever the patient gives the feedback, these all things adds to the cost of evidence-based practice. So now the play has come between regeneration or replacement. Me being an orthopedic surgeon, we are fighting with the fellow orthopods to regenerate the tissue than replacing the original tissue. How much ever possible, we have to regenerate the tissue. This is what the current era says. So what is basically tissue engineering? It is nothing but a new strategy as in vitro or in vivo regeneration of any tissues along with stem cells, biocompatible scaffolds, micromolecules to produce an engineered tissue. Whatever the engineered tissue has been regenerated, it should restore the normal tissue function and maintains the tissue homeostasis, which also improves the biomechanical strength of the original tissue. So the basis of tissue engineering are three things. One is cell-based therapy, second one is biomolecules, and third one is scaffold. That is what is being illustrated here. So the next one is today topic proper is autologous peripheral blood derived orthobiologics, that is called ABPO or autologous peripheral blood derived orthobiologics. So the first one everyone tells about platelet rich plasma and followed by platelet lysate, autologous condition serum, gold induced cytokines, platelet rich in growth factor concentrate, autologous protein solution, platelet rich fibrin, hyperactive serum, autologous condition plasma. There are various things only with platelets. These all things derives only from peripheral blood. And other than this, one thing is called, these are all acellular products. All are acellular. They doesn't possess cells when it reaches the site of action. Only one cellular product out of peripheral blood is peripheral blood derived stem cells. So along with this 10 things what I have mentioned here, we will be discussing a few things about peripheral blood derived stem cells as well. So the first one is platelet rich plasma. So at the end of first centrifugation, we will get the column of 3-column concept. Plasma, WBC layer that is called Buffy code, and the below one is RBC. So this is how it looks when we go for a second centrifugation. At the end of second centrifugation, we will be taking out this plasma along with Buffy code to do a second centrifugation. At the end of second centrifugation, we will get a full column of Strogler fluid, where upper 2/3 will be plated poor plasma and the bottom 1/3 will be plated rich plasma. When you take a section of Leishman's stain, the staining in the left whole blood shows very less platelets as being visible here. But when PRP is done with the Leishman stain, the blue colored dots is completely, the slide is completely filled with blue colored dots, tiny dots. This one, this one, this one, and all these tiny dots are platelets. So a platelet rich plasma contains 94% of platelets. So this is at the end of first centrifugation, plasma, Buffy code, and RBCs. This is at the end of second centrifugation. Top 2/3 will be plated poor plasma and bottom 1/3 will be plated rich plasma. So now I'm going to discuss a few examples where all we have been used. So this is muscle tear, that is gluteus medial muscle tear. In preoperative ultrasound, we could be able to appreciate the tear when one shot of platelet-rich plasma has been given at the site of injury. At the end of 4th month, there is a complete tissue integration, that is muscular integration at the tear site. The second example is Achilles bursitis. See the thickness of bursal thickness. This is the bursa. This is the Achilles tendon. The bursa has been inflamed. One shot of PRP has been infiltrated in the Achilles bursa.
Recording in progress.
That Achilles bursa has been, the thickness has been reduced at the end of 8 weeks. The next example is plantar fasciitis. This we will see day-to-day practice in OPD. We used to get minimum 2 to 5 cases of plantar fasciitis. It is a self-limiting disorder, but sometimes it will go for recalcitrant disease. At the time, we will be giving PRP. So the thickness of the plantar fascia has been measured. It is 6.04 mm at before injection. At the end of 4 months, the thickness has been reduced to 4.93 mm. So a vast difference is being seen at the end of 4th month. So this also proves that platelet-rich plasma is very good in plantar fasciitis. Now comes to cocktail of PRP in delayed union of fractures. This is a 28 years male, sustained trauma to the right thigh with the distal femur fracture on 20th March 2019. It does not show any union till 11th September 2019. Started on autologous PRP injection on 21st September 2020. So this is the picture of the scenario of the fracture. It has been treated with distal and femoral nail. It has not got united. Then we have gone for PRP injections. Here the protocol we used is 3 doses of PRP regularly at 3rd weekly interval. So from 1 dose to 2nd dose, 3 weeks gap has been given. So this is the needle is able to pass through and through. So this is at the end of 2nd and 3rd injection. This is at the end of final follow-up. Just see how beautifully it has integrated. The next case is PRP cocktail in 43 years male. This is a multiple injury patient but we went for conservative management of humerus fracture, Midshaft humerus, on 12th October 2019. The patient was managed with UCOS for 6 weeks, didn't show the union till 21st December 2019, and we planned for autologous PRP injection. See the fracture gap, it has not united till the December, and we started with autologous PRP, 3 dose, same thing. The needle is able to pass through and through inside the fracture. See how beautifully, see the callus formation, how beautifully the callus has been formed. This particular cases has been published in the Journal of Orthopedics, autologous PRP in delayed union of lumbus quasi experimental study. This has been already published. Now I'm going to show a few evidences from my team. We have published a few evidences also. It is a systematic review and meta-analysis of RCTs, which shows which is the best for lateral epicondylosis, that is tennis elbow, whether leukocyte poor or leukocyte rich. PRP, we concluded that PRP is safe in terms of clinical improvements in pain and functional scores in both types of PRP, that is leukocyte rich or leukocyte poor, which offers the similar results which has been published by other literature as well. And one more thing is Prisma complaint network meta-analysis we have done, where we have shown that leukocyte rich PRP is better for lateral epicondylitis than leukocyte poor PRP. This also has been published in Telenephrasis Journal. Next comes rotator cuff injuries. In rotator cuff, whether there is any evidence for PRP in terms of partial rotator cuff. Yes, in partial rotator cuff, it is better to use it. We have given level 2 recommendation. So intraoperative use of PRP at bone tender junction augments the healing rate, reduces the tear interface, and enhances the functional outcome and mitigate pain relief in patients undergoing surgical procedure, that is arthroscopic rotator cuff repair. The next modality is PRP in chronic wounds. See the edges of the wound, how it is. At the end of 3 injections, a 3-weekly follow-up, we used to give 3 injections. See how beautifully the tissue has been healed. These are the other examples of our case. There is one such example. Just 3 doses, autologous PRP. Now comes to exploring the role of PRP in lumbar disc disease. This is published in AO Spine Journal from our team. We have found it some beneficial effect in controlling pain, but we couldn't see any structural or functional improvement in the studies which have been published. So this area needs a potential research to prove that PRP is or regenerating the disc which has been showing disc bulge. Then we explored PRP is effective in enhancing spinal fusion. This is also published in AO Spine Journal, that is Global Spine Journal from our team. But we couldn't find a concrete evidence. We have told yes, it is helping in spinal fusion, but the role is very, very limited. This is also the potential area for further research. Next modality of APBO is platelet-rich fibrin. From the venipuncture, this is single centrifugation method, 2700 RPM for 12 minutes. A clot will be formed in the top. This clot contains fibrin. It's a fibrin clot which contains platelet in the meshwork of exoskeleton. This platelets will degranulate and alpha granules will release growth factors along with fibrin. And this picture depicts that there are different types of PRF. That is called advanced PRF plus, injectable PRF, titanium PRF, growth factor impregnated PRF. Among all these things, I use IPRF, that is injectable PRF, because in joint injections, if we inject injectable PRF, this PRF will go and binds into the joint and it will slowly elutes your platelet-rich plus, that is growth factors. And one potential area where we worked upon with PRF is non-healing ulcers. We worked with both PRP as well as PRF. See how beautifully it integrates at the end of the follow-up. The next one is, does PRF in ACL reconstruction enhance graft healing and maturation? It is one of the original study which is, it is not from my team, it is already published one. It has shown at the end of follow-up, It has beautifully integrated that PRF enhances the graft healing and maturation than without PRF. And one particular study which we have published from our team, we explored what are the role of PRF in musculoskeletal regeneration. The first A image shows rotator cuff injury where we have, this is PRF. We have integrated with PRF. So the PRF has gone for proper healing. This is meniscal injury where when we augment the meniscus, we have kept a plated-rich fibrin clot over there, which has integrated at the end of 12th month. C image shows chondral defect where while during the chondral defect, we used to do bone grafting earlier days. Now we are giving chondrocyte implantation, that is autologous chondrocyte implantation. After giving chondrocyte implantation, we will be closing that chondral defect with platelet-rich fibrin clot, which will give you the very good integration of tissues at the end of 1 year follow-up. At the end of 1 year follow-up, all these three images, patients were followed up with MRI, which has really shown a good results. The results are yet to be published. The other forms of PRF, which is in recent research, are PRF lysate, lyophilized PRF, and albumin-rich PRF. These are in research phase. Next comes growth factor concentrate. Here, growth factor concentrate, again, we are taking platelet-rich PRP and subjecting it for ELISA. Once you subject it for ELISA, you have to quantify the amount of growth factors. Then only we can call it as a growth factor-rich concentrate. So this is one thing. These are the 5 growth factors which are essential for any tissue to get rejuvenated and regenerated. So we have explored the role of GFC in non-union. We can see the gap, fracture gap. This is after fixation, after 4 months to 9 months, depending upon the site of injury, we call it as a non-union. When patient comes with clinical signs of non-union, we have injected 3 doses, 3 weeks apart. So at the site of, under CM guidance, on the site of non-union, we have injected that growth factor concentrate that is derived from autologous peripheral blood. So at the end of final follow-up, there is a good callus formation and good host tissue integration as well. This is another case. It's a proximal tibia which is operated with interlocking nailing. At the end of final follow-up, there was a good regeneration and host tissue integration along. Here, both bones have been involved. One bone we have treated with nailing, the other bone conservative management. Both bone has got good callus formation. This is one another case where the ulna, single bone injury is always a culprit which will not allow the other intact fellow bone. See, this intact fellow bone which never allows the single bone fracture to unite. So we have given a cast initially, it didn't unite. We have given a window in the cast. Here a window has been made and proper PRP inject, leukocyte-rich PRP has been taken out and growth factors have been quantified and further the case has been followed up. So GFC has been given, which shows a good union. Now, the other modality is partial TL ACL with PRP augmentation we have given, and the final follow-up shows a good reintegration. The tissue has been formed very nicely. This is one another modality where we have given nanofat and SPF that also has regenerated and integrated the partial tear of ACL very conservatively. And one another modality we have tried with IPRF. This also has given a good regenerate of the ligament, ACL ligament. Next comes to stem cells. Now I have dealt with few modalities which are currently in practice, and the other is stem cells. Among this, all the other stem cells are derived from different tissues. Only peripheral derived MSCs we are taking from APBO, that is autologous peripheral blood derived orthobiologics. So as everyone knows, cellular therapy, these cells have 2 properties. One is self-renewal, that is called an MSC can renew itself to form another MSC, and MSC can differentiate into different type of cells, that is ectoderm, endoderm, and mesoderm. Here, as an orthopedic surgeon, I am more concerned about mesoderm, where we can form bone cell, fat cell, cartilage cell. Only myocyte is from endoderm for us. So how to harvest peripheral blood mononuclear cells, that is called MSCs. First, we have to give filgrastim, 2 days for filgrastim, see the mononuclear count, then derive the peripheral blood, do centrifugation method, collect PBMSCs, then use it for further usage. So all these areas we can use, but as a cell therapy, I'm more interested in regenerating the cartilage. So the further research on all APBOs depends upon standardization of dose and frequency of injection, universal protocol and preparation methods and injection techniques. Main thing is quantification of growth factors and cellular components, whether autologous or allogenic is very, very important. Radiological documentation on bone or cartilage tissue regeneration is very important. Finally, once we are talking to an public forum, we need to have a RCTs, our own reviews or research or meta-analysis to state, yes, it is working or not. Now, I am including a few things on primary ONE with cellular therapy. This is my potential area of research where I have done my PhD also. This is the preliminary case which we have done, dates back in 2019. One side we treated with BMAC and the other side we have treated with SVF. Finally, see, this is the initial picture. Finally, we have come to a conclusion after 2 years follow-up. Yes, SVF has shown good, better outcome than BMAC. This is one another study. We have given bilateral knee. This is pre-procedural image. B image is 24 hours post-procedural image. SVF has given the thickness of the cartilage is not worn out and it has been improved. We tried with nanofat. The similar results have been obtained. These are all the byproducts of adipose tissue. And we have followed up with T2 MRI, which has been taken from, why BMAC T2 MRI have put us here. T2 MRI shows the thickness of the cartilage has been improved or not. So BMAC was safe and no superiority to saline injection. BMAC in this MR cardiograms failed to show regenerative benefit with single BMAC injection. This study was published in 2018. See, it has not shown anything here. On the upper are pre-procedural and below are post-procedural. There is no subtle increase in cartilage thickness. Then, stromal vascular fraction has been given for patients. This is a very famous group. They keep on doing particular studies and they will publish the results. 12th month post procedure, they have done a T2 cartilage imaging, which has shown subtle increase in SBF. And from our team, we did a literature survey. We want to see which is the ideal source of cellular therapy for cartilage repair. We found out that stromal, apart from adipose tissue, synovial stem cells stands the first one, followed by adipose tissue, then bone marrow MSCs. When the other types of MSCs, when you mix with the chondrogenic factors like SOX9, it will enhance its potential. For example, amniotic fluid, placenta, umbilical cord, endometrium, peripheral blood, and periosteum. We have come out with a meta-analysis which source of MSCs are good for ONE. We came out with an answer that is adipose-derived MSCs. One another critical review also we have done recently in 2023. Here also we have proved that adipose tissue is better than bone marrow. So this is these are all my PhD workup. SPF isolation characterization. We are doing direct sonication. The image shows direct sonication, which is a patented technology where we have done few cases. Grade 1, 2, 3, and early grade 4, grade 3 is included. Grade 4 I have excluded. We have done randomization. So SPF patients 115 and saline patients 116. In SPF group, we have got improved Q score at the end of 36 months and decreased VAS score at the end of 36 months. And this study has been published in Indian Journal of Orthopedics from our team. And one more entity called here osteogenesis, that is avian hip. Post COVID, we have got a lot of avian. Grade 1 is involved. Grade 2 we included. Grade 3 with caution. And grade 4 we have not involved. And similar technique is followed with mini decompression. This particular study also has been published in Indian Journal of Orthopedics. A few cases I am showing here. left hip AVN, we have done mini decompression followed by SPF implantation. This is at the end of 4th year follow-up. This is the A is pre and B is post. The head of femur, still it shows the volume of femoral head is being maintained. There is no deformity or disintegration of femoral head. One another case, right side, here we have given mini decompression is done with a needle decompression along with SPF implantation. ABC or pre-procedural image, DEF or post-procedural image at the end of 3 years follow-up, still it is being maintained without any pain and improved function. This also has been published in Indian Journal of Orthopedics last year. So the further things in APBO or any form of regenerative modality, as first speaker Manas told, gene therapy has been come out. It's coming out still. It is in the in ex vivo phase, yet to come with clinical trials. The next one is MSC-derived secretomes. These are all very good modality. It contains soluble fracas and extracellular vesicles. So it also has given a good potential. Lot many papers have come out. Already literatures are there. And last modality is extracellular vesicles. This is a part of secretomes, but this is more focused and it was highly regenerative potential. We have small EVs and large EVs. Small EVs are very, very good in targeting the site of action. And small EVs, we have 3 things: exomeres, exosomes, and ectosomes. The sizes have been given, mentioned here. And large EVs are nothing but migrasomes, apoptotic bodies, and large oncosomes. Now I'm more focused and towards exosomes research in osteoarthritis. So MSC-derived exosomes have been explored by our team. It has immune factors and growth factors. Here we have our team has come out with 3 papers in exosomes on ONE, which is already published. And this is the recent one, which is published in 2022 in Journal of Experimental Cell Research. We have done few reviews. Now original studies, we will be taking up a clinical trial soon, after taking permission from the authorities. And these are all the available over-the-counter cellular therapies, which will be dealt in the part 2. So all this regenerative therapy or stem cell therapy has been put together as a ATMP, that is Advanced Therapeutic Medicinal Product, as an Indian perspective. So in India, this is regulated by SEDESCO, ICMR, DCGI, and DGHS, where they have given criteria for minimal manipulation and more than minimal manipulation. We all have to follow only minimal manipulation of cells, not to alter the biology of the property of the cell. So this PRP or peripheral blood derived any form of orthobiologics come under low risk, which doesn't require any oversight of any regulations. A normal ethics committee regulation is enough. And class 2 lower risk, where bone marrow products and amniotic membrane without cells, all these things come under 361 regulation. And the third one is higher risk, which contains section 351 regulation, where we have umbilical cord, exosome, and amniotic fluid cells. So ethical concern 351 deals with the regulation of drug and biological products. 361, it is a non-subjective to pre and post-marketing surveillance. So what 361 says, it gives you 4 criteria. One is minimal manipulated, as I told. Homologous use. Third one is it should not involve with any other cells, like except for freezing, thawing. You should not add any antibiotics or any form of other cells to make it as a drug. And fourth one is whenever injected locally, it should not give any systemic side effect, or it should not alter the biology of the metabolism of the primary living cell. Out of all these 4 things, this homologous use we cannot maintain. Homologous is nothing but, if today's topic is APBO, that is autologous peripheral blood derived orthobiologics. When you are taking peripheral blood, you are supposed to return that product only to treat the peripheral blood based disease. But we are instilling it to cartilage, tendon, bone, everywhere. So we cannot maintain this word homologous. So to sum up, this is a novel biological approach in osseous cartilaginous regeneration. It is immunomodulatory, anti-tumorigenic, immunoprivileged modality. It gives you robust pocket of cytokines, growth factors, and BMPs, that is bone morphogenetic proteins. The main thing is induction of interleukin-1 receptor antagonist, that is a anti-pain. Anti-inflammatory molecule. It reduces your pain. And I already told a few words about exosomes, secretomes, and gene therapy. And section 351-61 also has been discussed here. So the take-home message is, whatever ABPO we are giving, it is not volume dependent. We cannot argue with 1 ml is enough, 2 ml is enough, 3 ml is no. It depends upon platelet characterization, whether we have given dead platelet or live platelet. The viability of platelet is very important. Other than that, more than platelet concentration, growth factor estimation is very, very important, because all the modalities, 10 modalities, whatever I have told, ACS, ACP, Goldic, cytokines, all these things talks only about growth factor quantification. And radiological documentation is very, very important to say whether it has improved your thickness of the cartilage or whatever tissue of interest you are going to regenerate. We have to show radiological documentation. Finally, whether it is autologous or allogenic, platelet lysate and all, we can do both autologous or allogenic to treat the disease. So my interest now towards already our one of the moderator have told, yes, we are very much interested in developing a scaffold. My team, she is Dr. Chitralekha from our institute, from Virginia Tech, India. We are developing some scaffold. This is the preliminary scaffold we have developed, yet to go for clinical trials. Now we are in the process of patenting. So always think about innovation, add something new to the value of what is being already circulated in our scientific community. So this is my team with AIMS Delhi and Dubai. We are doing many research in scaffolds. We are doing 5 to 6 scaffolds. We are under characterization. Soon we'll be publishing the results. This is my team who we are working very in milieu to come out with some products in near future. This is out of interest. I just put up this particular 4 things. Now regenerative medicine has come up with HIV cure, but not with ABPO, but with stem cells. In whole world, these 4 things have been already published over the whole world. Out of 4 people, one is a lady. The first one is a middle-aged woman from Berlin. Second is the undisclosed identity. The identity is not disclosed, but they have told it is a man. And the third one is middle-aged female, 66 years man from US. These all 4 persons have one or the other form of lymphoma or leukemia. While treating lymphoma or leukemia, they had HIV RNA. When they have been treated with stem cells for leukemia or lymphoma or any form of tumors, hematological tumors, they have been reported they cleared RNA virus of HIV. So HIV RNA has been cleared off from the blood, and they have been declared HIV-free individual in the whole world. These 4 people have been publicly disclosed, and it is already published. The data is available in internet. So it is already disclosed, and whatever it has come out in newspaper media, I have just pasted here. So these are all my societies and my university who was helping, and my association organization, Tamil Nadu Orthopedics, Madras Orthopedics, Indian Orthopedics, those are all helping me in doing this research. And my university, from Sharda University to MJ University, all are supporting me very well. And the final thing is my lab from Mother Cell Regeneration Center, Trichy, they are supporting in my further research. And this is me. I'm happy to collaborate with anyone for any studies or any clinical workup or any publications. I'm happy to take any questions. If you have any questions, I'm happy to answer here. Thank you.
Thank you, sir. I think you have opened a Pandora box for all of us.
Recording stopped.
Because this was a very, very detailed overview. I can still say this is an overview. You must have done a lot of research in each of these topics. And this is just an overview of what all things are possible with this new treatment modality, definitely. I will just see if there are any questions. Varsha ma'am, if there are questions you want to ask, you can ask directly. Till then, I will see in the chat box if there are any questions.
Can I ask? Can I ask?
Yes, ma'am. Krishna, ma'am. Go on.
Yes, ma'am.
Yeah, actually, my question is whether you, what way, if it is a knee osteoarthritis, how he gives? Is he gives us suprapatellar, or he gives the intraosseous, or just fluoro guided inside the joint, or just ultrasound guided suprapatellar space?
It's a very
So
good
how he gives?
question because nowadays we are telling intraosseous plus subchondral works very well. Intraosseous, subchondral plus intraarticular. These three modalities work very well. This is the literature evidence. But recently I have started with regenerative modality giving in subchondral area and intraarticular. So I
So,
have to wait for one more year to say my results. But research which is already published says that combination of subchondral or intraosseous with intraarticular is very good. And Madam has asked one more doubt: which approach to give?
yes.
Supralateral portal or in the joint line? Joint
Yeah.
line also we can give, but supralateral portal, what I found difficulty is sometimes if the needle is not penetrating till the joint area, it is we
Yeah.
are just depositing the solution in the supralateral aspect, which is giving a little swelling over that particular area, and it is not entering the joint per se. This I have found because I'm not telling it is not a good modality. Yes, you can you take a long needle and see in ultrasound and go till inside the joint to give an injection. Apart from intraarticular, just give one shot of injection in the infrapatellar fat pad because infrapatellar fat pad is a rich source of synovial MSCs. Because
Yes.
synovial
Right.
MSCs are very good for cartilage regeneration. Even if we are giving PRP is an acellular product basically. All these things APPO except peripheral blood derived MSCs, other APBOs are all acellular. When we are giving acellular modality, just give an injection in the infrapatellar fat pad. That will boost your synovial MSCs in that particular area and it will give you a better regenerative modality over that particular joint.
Yeah, I also find if I combined with the intrapatellar and the suprapatellar both mix, that patient gives the better result. One more thing, the intraosseous, so that you give under local anesthesia and means or fluoro
That
guided,
is
how you
very
give?
difficult. Yeah,
How
it
you
is
give?
very difficult. When we are planning for, when we are giving intraarticular, we won't give spinal or any other anesthetic agent.
Yes.
But
Yeah.
when we are going to poke your bone, definitely the patient will not allow us. It's better to give under TIVA. Under regional anesthesia, just go with bone marrow needle is there. No, that is self-sufficient because it is
Yes.
either 11 gauge or 13 gauge. Just go
Yes.
inside with the help of bone marrow needle. Just go inside and give the injection. But
So
it
how much
definitely
you
needs
give?
an anesthesia.
If if you give like SVF for the BMAC, how much you give there? The first means the main content you give intraosseous or how you give?
Both to be combined, ma'am. I'll give both intraosseous and intraarticular.
The intraosseous, how much you give?
Ma'am, it is not my protocol is I'll give per kilogram body weight, ma'am. I have a cell counter here. Before injecting, I'll try to validate whether 2
Okay.
million cells are there or not for per kilogram. So if I'm 80 kgs, for example, I'll be taking 160 million cells. So 160
Okay.
million cells will be divided into two for two knee joint. So one knee
Okay.
joint, I'll be delivering 80 million cells. So this
Okay.
80 million cells will be, for example, this 80 million cells are coming up to 5 ml. I'll divide into 2.5 ml, 2.5 ml. 2.5 ml I'll be giving inside directly into the intraosseous portal, wherever, whether I'm giving subchondral or intraosseous. The second
Okay.
2.5 ml I'll be dividing into 1.25, 1.25 I'll be giving in the both knee joints. I mean, medial and lateral joint line. And PRP, I'll prepare PRP 1 or 2 ml that I'll be injecting into the infrapatellar fat pad.
Okay. Okay.
Whatever
Okay.
regenerative modality I'm going to plan for a patient, I will take some amount of peripheral blood to prepare PRP. PRP always boosts your cellular therapy.
Okay. And if you are giving the subchondral, so will you give in the tibia and femoral condyle both or how? You decide
No,
where
ma'am.
you
Till
will
now,
give.
I have practiced only femoral condyle. It is a very good question, but tibial condyle till now I have not given. I have to try still.
So femoral medial condyle, of course, right?
Medial condyle only, ma'am. Medial condyle.
Because that is the most affected. And if
Yes,
it is
yes.
a subpatellar chondromalacia, then what you give? Means under the
That
patella?
I will make the patient to keep the knee joint flexed under C-arm guidance. I used to inject in the undersurface of patella. But this
patella.
needs anesthesia, ma'am. We cannot give without anesthesia because chondromalacia patella, we have to little scratch up the patella undersurface. That with a needle, if you poke, if a patella is like this, if you poke below, the patella will be very soft. It will be lined with a cartilage. The cartilage is very sensitive. If you go and touch with a needle, it will give a lot of pain. Better to give a TIVA. Once you prepare all the cells, if you are going to give a injection, push propofol, like how you push for TIVA, then you just do a zigzag needling technique over there. Ma'am, it's not about knee joint. Wherever you are injecting in any tendon, if you are giving a blinded injections or controlled injections or ultrasound guided injections, just try to poke. If I'm going to give in this particular area, I just put a needle inside, just try to poke 1 or 2 times so that it will create a bleeding spot on whatever we are giving, wherever we are giving cartilage or tendon or ligament. All these things are not very much vascularized tissue. It is all less vascularized. To be frank, cartilage is avascular. We are not knowing about tendon. If it is a muscle, it is a vascular tissue. But while coming as a tendon, it is not that much vascular, right? So just try to poke that area 1 or 2 times so that it will give you some bleeding spots. So this bleeding spots, along with that, if you are injecting that APBO, any modality, this will go and bind that bleeding spot. That bleeding spot will give you a fibrin release also. So whatever PRP or ACS or Goldic we are giving, it will go and bind to that and it will give a good action.
So do you use the PRP with the BMAC also or the only the SVF? Because BMAC, it has the blood part, right? Some of that.
Or there is nothing harm in using PRP along with other cells also, because PRP is going to give only your growth factors. It is going to give a lot of growth factors other than cells.
Okay. And for the hip AVN, when you are using for the grade 3 also, will you do the every case code decompression or we can inject in the head?
The issue is in grade 3, we have 2 grade. In grade 3, we have subsections A and B. Okay. When we, in grade 2, we have A and B. Grade 3, there is called something called early grade 3, late grade 3. In early grade 3, there will be foci. Everywhere the foci will be there. But the only thing is, if the head is not getting collapsed, if the head shape is still maintained, then I will do only mini decompression at the area of necrotic tissue. If there is complete necrosis of the head is there, for example, and it is between early and late grade 3, then I'll go for core decompression. Core decompression also I'm not doing with triple reamer. I'll go with multiple drill holes with 4 mm drill bit. Cannulated drill bit.
Okay. When you're doing a needle decompression, then you just go through the fluoroscope and just do the needle, or you open and do? How you do?
Ma'am, I have done few cases without opening the joint, like mini decompression with the needle decompression. But when I'm not sure about, okay, if the patient is having a lot of necrotic area, the head may, we can sense, ma'am, on seeing the MRI, we can sense that whether the patient may deteriorate fast. That means then I'll open up, I'll put 3 to 4 4 mm drill holes, then I'll fill it with whatever regenerative modality. Finally, I will close it with PRF gel, PRF, not with bone wax. Initially, I have done with bone wax, but I'm not getting a good response with bone wax. So when I'm giving some form of regenerative therapy, I'm using only, nowadays I'm using PRF gel.
Okay.
One thing, once I reamed, I never give a wash after putting stem cells of regenerative modality. Before going to inject all the cells, I'll give a wash, give 5 to 10 minutes of relaxation for everything to come out. Then I'll use a suction apparatus to suck all those washable materials and all. I never use any antibiotics here. but I use only this regenerative medicine modality. I will just infiltrate inside the tissue, then close it with a PRF gel, then suture it back.
So when people are doing arthroscopic repair, that's why I was strange. So they also do after wash and everything, they just put up the regenerative therapy. Otherwise, it will be washed away with the fluid.
Yes. It's a very good question. Arthroscopy will be continuously irrigating the particular area, any joint. So once it is done, we'll be take full joint, whatever fluid is there inside the joint, we will take it out. Once it is done, we will inspect the whole joint. Then we will give the injection at the site of action. Then we'll put a clot, PRF clot at that area. After placing PRF and regenerative modality injections, we never touch the joint. We'll come out, we'll suture whatever it is.
But you give IV antibiotics, right? Not the localized.
IV antibiotics we have to give because we are taking a scope and putting inside.
Yes.
We are not, even though we get a lot of sterile instruments, we are getting chances of infection. So better to combat that, we'll give IV antibiotics as such.
Okay. And but you don't give any NSAID, right? You give only the paracetamol or the opioids.
Only paracetamol. Sometimes if the patient is not bearing the pain, this peripheral blood-based orthobiologics, sometimes it will go for synovitis. If you have noticed, the patient will come with severe pain. That time I advise only ice pack application and tramadol. Tramadol to be infused over 500 ml of NS or RL something.
Okay. Okay, Dr. Madhan, thank you so much. And your results for the ABN means how many years? I have seen 1 or 2 papers, 6 years studies for the ABN.
My study, we have published is 6 years, ma'am.
6 years, your study, So 6 years you have seen.
The problem with regenerative modality is if the patient is getting cleared of the pain or whatever the disease may be, following up that particular patient for a longer period of time, they are not coming back. That one vessel I have. That's why in all the studies, there will be a lot of dropouts after 2 years or 3 years. If I'm planning like I have to follow up the patient for 10 years, it is really not possible.
And in osteoarthritis knee, how many years have you seen for SVF or BMAC? Because PRP, BMAC, I don't think it's a long...
8 years I have seen, ma'am. 8 years. Ma'am, but whatever cells we are giving, the patient also should cooperate with putting the braces, doing exercises, not by sitting cross-legged in the floor and all. They have to also practice whatever we are telling. But patients ultimately fail to do that.
Yeah. So, but you have seen the best result with the SVF than the BMAC.
Yes, ma'am. Best result is only with SVF, ma'am, because your adipose tissue has more potential for chondrogenesis than osteogenesis, ma'am.
Okay. Because PRP, actually speaking, in the knee, I don't get much better result. BMAC I'm doing and I'm getting good result, but
PRP or any form of APBO, we need case selection, ma'am. If you do in grade 1 or grade 2 ONE, definitely it will work, ma'am. But the patients have to accept the modality. That's all.
Okay. Thank you.
We, the regenerative medicine experts, we will be talking about regenerative stuff. But other fellow doctors, they are not convinced with regenerative modality. They'll be convincing for any form of hyaluronic acid or any surgical modality or steroids.
Mainly surgical.
Those things are very much hassle for any regenerative medicine expert to convince the patient.
Yes. Yeah. Thank you.
Thank you.
When are you doing, when you are doing SVF, then how many sessions of PRP generally you do, and at what gap with the SPF treatment you generally do it, or you do it only SPF?
I have done 2-3 studies. In that one study alone I have published. With SPF alone I have published. SPF with PRP I have not published till now. The patients are on treatment and follow-up is ongoing. But my protocol is on same surgical sitting. Your patient is getting admitted for today, SPF, any modality. For example, if you take ONE, I'm doing minimal manipulation in the same surgical sitting, I'm doing SPF. After 3 days, before discharge, because SPF, I'll be drawing fat from abdomen. that liposuction area is very much important to do dressing. So at the third day, I'll be discharging the patient after seeing the bruit or oozing out all the fluid. So at that third day, I'll be giving one shot of PRP. Then after a month or minimum 3 weeks gap, I'll give, sir. I'll assure that 3 weeks gap should be there between first dose of PRP and second dose of PRP. Usually 3 doses I'll give, sir.
3 doses of PRP. Okay, I will take just 1 or 2 questions that are there in the chat box.
Yes, sir. Yes, sir. Please.
One is, have you encountered any case? So you have done PRP for intradiscal PRP, and if yes, then have you encountered any case of discitis post PRP?
No, sir. Till now I have not encountered any discitis. But only thing is PRP is not sufficient for any discal pain.
Yes.
Pain relief will be there, sir. It will be there only for a short time. But if you want a long-lasting one, then we have to think about any cellular therapy.
Because there were many case reports coming where there was, you can say, aseptic inflammation or aseptic discitis type of picture that was developing post PRP injection inside the disc.
So it will be there. If you take the biology of PRP, once you inject something in somewhere, there will be increased inflammation. That is called, that's why we used to get synovitis in our knee joint. The same kind of inflammation can be there in many other places also. That discitis, if it is an aseptic discitis, it will resolve on its own, sir. Nothing to do.
Okay.
Now, one of my patient also took 3 months, but got, when there was no discitis, but she has the increase of the pain. Then she become all right after 3 months. But
no, there will be, ma'am, any form, ma'am, any place, if you give any modality, there will be increased in pain because that is the biology only. It is normal biology. If any fluid, if you give in any joint or area, it will go for inflammation because whatever we are isolating, it won't be leukocyte free. Definitely, it won't be leukocyte. Even one leukocyte is sufficient to do an inflammation.
Yes, yes.
I had one case. Hello, can I speak? Sanjog?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am. Please.
Yeah. Because I encountered last year 2 cases of discitis in spite of taking all precautions. And it was really tough to manage them. It took nearly 3 to 4 months with lot of antibiotics, and ultimately, like decompression had to be done. They had to go for surgery. And what I mean to say is with fixation. So that is why I was asking.
We cannot explain. That's what, ma'am. We are giving for pain relief. But after taking all precautions also, we are getting infection. Don't think about regenerative therapy. If you take TKR or THR with so much of precaution, we'll fumigate the OT for twice before going for any replacement.
Everything. We take all
in spite
precautions.
of it, we may get. There is a chance.
May get. So I stopped giving then in the disc. I said no, nothing.
Whatever we are giving, write a proper consent. Consent form, if you take a proper one, in, I don't know about the Hindi language. So if you take both consents, local language as well as English, take a detailed consent. Even for a small PRP injection, take a detailed consent because these are all not approved therapies. These are all like other, like not point of care. This is like a clinical option or a clinical opinion or a research kind of things. Still, none of the societies have approved, no, ma'am, legally. So it's better always be very, very cautious in giving an injection.
This is only with the test,
regenerative therapy is like a double-edged sword. It can take you to the higher also. It can take us to a lower pole also.
Exactly. Ultimately, they got better, but then they had to proceed for surgery with fixation. So that is why I was asking, have anyone else encountered this?
And we will be knowing that it will reduce a pain relief. It will give a pain relief. But the fellow surgeon or a anesthetist, they will tell, no, this won't work. At that time, the patient will get a bad opinion on us that we have done something wrong. There are a lot many things to be tackled upon before doing one single case.
Yeah, agreed. Thank you.
Thank you, ma'am.
I'll take this last question and then we can wrap it up.
Hi, Dr. Sanjog. How are you doing?
Hello, sir.
Hi, how are you?
I'm fine,
Madhan, great talk. I heard it through and through. It was wonderful and nice you educating, the very needed topic these days. 2-3 is important things I want to kind of detail with you. One is when you're doing knee work, are you doing genicular RF also or not? Are you educating genicular RF or not for pain?
Sir,
I
if
hope you
your
got the
voice
question.
was not
Yeah,
audible,
did you get
can
my
you come
question?
again, sir? Genicular?
Genicular radiofrequency for pain relief. Genicular
Okay.
radiofrequency.
Okay. Sir,
Are
sorry,
you
I'm not using
combining?
that particular
Are you?
modality.
Okay. Okay. That's
I'm not
important for
using that.
pain relief, you know, because the regenerative medicine will take its own course of time for a few weeks. Till then, you can do a genicular RF for pain relief. So that's a very, very good tool because patient symptom is pain. So you have to do a symptomatic relief. That is it. Another two things for the AVN. When you're doing intraosseous work in the from the lateral hip, are you doing any intra-articular injections also by the side of it?
Sir, when we are just reaming into the femoral neck through the head, sometimes our reamer may pierce the head also. So once you pierce the head, it is only intra-articular. There is nothing there. So giving injections in intra-articular also, it will rejuvenate a joint. That's all. But I have never found out any difference between intra-osseous and intra-articular. Both gives the
When
same
you said
results.
it may, you know, when you use the word may, normally the protocol here is that we do intraosseous work. We may or may not be able to go through the whole head because of the safety reasons. Then we do a separate intra-articular ultrasound guided injection of the region.
Sir, actually, it won't, even if you pierce the head, it won't do any harm, sir. Unless your head is in spherical shape. If your head contour is different, then we can't do anything. If the head is spherical shape, then you can go, sir. Nothing wrong.
Actually, do you, like we've been giving bisphosphonates like zoledronic acid or denosumab, are you educating that by the side of that as a treatment part?
Sir, bisphosphonates, earlier I used to practice, sir.
Yeah.
Now, though, I'm not using any bisphosphonates, but I used to give denosumab when a patient is severely osteoporotic. Denosumab every 6 months once for 2 to 5 years.
And normally these patients are young patients. They're not really osteoporotic. These are most.
Then no need, sir. Just calcium, vitamin D is sufficient, sir.
That's what I'm saying. So that's
so one more thing here I like to add.
Zoledronic itself per se is a good modality in early cases. So we thought, can we combine with the treatment of regenerative medicine with the zoledronic?
We can do that. Even if you give glycine or vitamin C based products, also it is very good for regeneration. Vitamin C, vitamin E, glycine, any fatty acids like omega-3 fatty acids, magnesium. One more is magnesium. For vitamin D's absorption, we need magnesium. Yeah. If you check magnesium levels, it will be very less in case of osteomalacia or osteoporosis.
But it was wonderful talk of yours. Means I'm really, quite pleased to see such a great work been done in Indian scenario. Compliments to you for that. Wonderful job.
Thank you, sir.
Keep it up. Keep it up. Very proud.
Thank you, sir. Thank you, sir.
Keep it up.
Okay, I will just take one question. Just your comments on combining visco supplements along with PRP or regenerative injections.
My views on visco supplement is, it is hygroscopic in action. First thing, if we combine the modality, if I place 2 needles, for example, in a medial joint line, if I put PRP, and lateral joint line, if I put hyaluronic acid, my school of thought is like this is hydrophobic. It is hydrophobic, HA. Your PRP is hydrophilic. This will go, both will cancel each other. That is my thinking. And there is a lot of studies combining both the modality has given good results as well, and it has given no results also. So still it is a concept of debate.
Because some growth factor companies that I had discussion with, their concept was is since they were increasing the quantity of interleukin-1 antagonist in that. So if we are adding visco supplements, so those antagonists will not be able to work along with
cancel each other. The problem is you are telling in terms of agonist antagonist. What I told is it is hygroscopic and hydrophilic. That's all. So if you use both in a different modality, it will cancel each other.
Yes.
If both are hydrophilic, it will act.
Okay. Great. Thank you, sir, for your great lecture and then discussion at the end of the lecture. I would like to invite Madhuri Lokapur madam and Varshari Kinia madam to please say some words, and then we can wrap up this session.
Well, Dr. Sanjog, Dr. Manas, and Dr. Madhan, a wonderful session. And after a long time, this is one of the topics and the presentations where I have really learned a lot. Actually, my brain is going into absolute this thing. We need to really, really accept this new topics. And I'm very happy that you have published them. And that's why there is a lot of authenticity and there is a confidence for people to try these out in their patients. So I'm sure our pain physicians will definitely help with that. Thank you very much.
Thank you. Thank you.
Yeah. Thank you. Thank you, Madhan. It was very elaborative and good insights for so many things that we can do with regenerative therapy. Yeah, and so many things to do. Thanks again for that wonderful talk. Thank you, Sanjog, and thank you, Manas. I would hand over to Varsha to end this session. Yeah, Varsha.
Thank you, Varshali ma'am. And first of all, thanks a lot, Dr. Madhan. It was really enlightening lectures. The way comments were flowing in and the questions were like unstoppable, audience wanting to know more and more. That itself indicates that how, lucrative this topic was. And it is unending. As you said, research is going on and whatever amount we can do and we can learn. I to feel abhi mujhe to, or like I don't know regenerative therapy at all after listening to your lecture. So I have to go back and start from the scratch. So great insight by Dr. Madhan. Very nice overview and start by Dr. Manas to, like Sanjog said, kickstart of our series of regenerative therapies. So both the speakers really did good job to start this webinar series. And thanks a lot, Sanjog, for moderating, for navigating us all and completing it the way it was expected by all. Thanks, Dr. Varshali ma'am, Dr. Madhuri, Dr. Krishna ma'am, Dr. Sunita ma'am. Like they are all currently leading ladies of ISSP, I should say. And thanks for contributing, discussing actively. Thanks to every audience, every person all around the globe. I could see many esteemed faculty join Dr. Neeraj Jain and contributing to discussion. Thanks a lot to our SSPP members who made this webinar message viral, putting across in every group and every friend who's practicing pain. And last but not the least, our partner, Anesthesia TV, who is really critical, taking all SSPP webinars since last 4 years, I would say. Since the COVID times, we are doing online webinars consistently every month. And Anesthesia TV has been the vital support in taking these webinars on live platforms, 5 live platforms on YouTube, Facebook, Anesthesia TV, and having around 1,000 of audience.
And compliments to Pune team. Compliments to
Thanks,
Pune
team. Thank you so much, sir.
Good job.
Okay, thanks, everyone.
So,
Bye.
yeah, good night and thank you. Bye-bye.